Let's talk about the modified stopper approach, which, as we know, has revolutionized anterior access to the pelvis, particularly for acetabular fractures. It was originally described by Stoppa for hernia repairs in 1975, but adapted for pelvic surgery by Hervensalo et al. In 1993. How would you compare this approach to the traditional ilioinguinal approach in terms of visualization and
The
exposure?
modified Stoppa approach certainly offers superior access to the anterior column and quadrilateral surface, which is critical in pelvic and acetabular surgery. When supplemented with a lateral window, it allows for excellent visualization and direct instrumentation of these areas. This is something you don't quite get with the ilioinguinal approach, where the quadrilateral surface is much more challenging to access directly.
Exactly. The ability to directly instrument the quadrilateral surface is a significant advantage, especially when dealing with complex fractures. During the stopper approach, though, we have to be very mindful of protecting the obturator neurovascular bundle and the lumbosacral nerve trunk. What precautions do you take to ensure these structures are
Protection of
safeguarded?
the obturator neurovascular bundle is crucial. I always make sure to use malleable retractors to shield these structures during the dissection. When exposing the quadrilateral surface, a spatula or malleable retractor is essential to avoid traction or avulsion injuries. Additionally, I keep a close eye on the external iliac vein, which can be in close proximity, particularly in the deeper parts of the
That's a
dissection.
good point. Missteps can lead to significant complications, especially if there's inadvertent injury to the corona mortis vessels, which are commonly present and can cause substantial bleeding. How do you manage these
Once I
vessels?
identify the corona mortis vessels, which are typically venous, I either ligate or clip them early in the procedure. It's important not to incise the fascia overlying these vessels prematurely, as that makes them more difficult to manage. Staying in the preperitoneal space until the vessels are clearly visible helps mitigate any risk.
Now, let's talk about the setup. I find that patient positioning is crucial for successful exposure. I typically position the patient supine on a radiolucent table with the injured leg included in the field. A bolster beneath the knee helps relax the psoas and vessels, facilitating the dissection. Do you prefer any specific modifications to this
Your
setup?
setup sounds optimal. I also prefer the supine position, but I make sure the leg is slightly abducted and externally rotated to maintain the best possible tension on the pelvic structures. Additionally, using a sterile triangle under the knee helps to avoid any unnecessary tension on the iliac vessels during retraction.
Once we've done the fan and steel incision and retracted the rectus muscles, how do you ensure safe and effective dissection along the superior pubic ramus and further into the iliopectineal
I
eminence?
start with careful blunt dissection to identify the pecten pubis. At this point, I use diathermy to dissect the periosteum and then continue with subperiosteal dissection, always mindful of the obturator neurovascular bundle crossing the quadrilateral surface. It's critical to mobilize this bundle early on and protect it throughout the procedure with retractors.
Absolutely. Another key challenge is controlling bleeding when we start elevating the iliacus muscle off the iliac crest. How do you manage this during the lateral window
Bleeding
dissection?
from the nutrient vessels of the iliacus can be problematic. I usually have bone wax ready to control bleeding during the subperiosteal elevation. In some cases, the vessels can be substantial, requiring careful cautery to prevent further
As we both
issues.
know, in certain cases, especially with more complex fractures, we may need to extend the exposure. Do you find the addition of a lateral window to be effective when further exposure is required?
Absolutely. When necessary, I extend the incision along the iliac crest, which provides full access to the internal iliac fossa and part of the SI joint. This gives better visualization of the posterior column, especially for fractures involving the SI joint or the posterior aspect of the ilium. It also overlaps with the exposure from the stopper window, which is quite useful for complex acetabular fractures.